Hello, everyone, and a warm welcome to today's edition of Patcast. Today is November 23rd, 2021, and it's Tuesday. And I'm Rifat Mannan at California, and I'm remotely joined by my good friend and colleague Emilio Madrigal, who is in Boston right now. Today, we are excited to welcome Dr. Kay Park, who is an attending pathologist at Memorial Sloan Kettering Cancer Center. And today she is going to present a talk on GYN pathology. I think this is going to be the 18th lecture in the series. And the topic of her lecture today is HPV negative cervical glandular lesions. And as always, please feel free to post your questions or comments on both YouTube and Facebook chat windows, and we will pass them on to Dr. Park at the end of the session. And thank you, Dr. Park, for joining us today. Over to you now.
Great, thank you so much, and thank you for inviting me. Today I'll be talking about HPV negative cervical glandular lesions. So I'm gonna go over just a very brief background, and then these are the three broad topics I'll be covering: malignant HPV negative glandular lesions, i.e. adenocarcinomas, precursor or potential precursor HPV negative glandular lesions, and then finally, very briefly at the end, I'll touch upon some benign HPV negative glandular lesions. So as you all know, cervical cancer, the vast majority is comprised of squamous cell carcinoma, but in recent years, the proportion of squamous cell carcinoma has actually gone down and the proportion of adenocarcinomas has gone up so that it comprises about approximately 25% of all cervical carcinomas. And as we know, nearly all cervical squamous cell carcinomas, with very rare exceptions, are caused by high-risk HPV. When it comes to adenocarcinomas, about 85% are caused by HPV, which means that it's a much more heterogeneous group of tumors, and that about 15% are not HPV driven. If you look at the old WHO classifications, both the 2003 and 2014, you can see that the glandular tumors were categorized just based on what they look like under the microscope, without any link to etiology or molecular genetics. And really, the future of cancer biology and treatment and diagnosis is not linked to just what it looks like under the microscope, but what drives the tumors and what therapies do we have to treat them. So in that vein, we undertook a study back published in 2018, the International Endocervical Adenocarcinoma Criterion Classification, or IECC. Now, I know Dr. Karen Talia gave a talk back in September covering this really well, so I'm not going to go into too much detail, but this was an international study where we looked at tumor morphology and tried to link it to modern diagnostic techniques like immunohistochemistry and HPV to try and come up with a classification system that's not just based on morphology, but also linked to etiology. And so it's a very simple system that anyone can do with just a microscope. You don't need special stains. But what we said was that any HPV-associated adenocarcinoma could be identified by seeing very easily identifiable apical mitotic figures and apoptotic bodies at either scanning magnification or sort of intermediate magnification. And if you couldn't see them easily and you had to go on high power and really search high and low for mitotic figures, then those were determined to be HPV-independent adenocarcinomas. And then we further subclassify them based on previously existing classification schemes, just to be in continuity with that. And what we found was that out of 371 adenocarcinomas, that the vast majority were in fact HPV-associated, either usual type or other sort of mucinous subtypes based on morphology, like intestinal or mucinous NOS, signet ring, or invasive stratified mucinous carcinomas. That left about 17.3% that were not HPV-associated, and of those, the gastric type is the most common, comprising approximately 10% of all cervical adenocarcinomas. And why was this important? Did it have any clinical implications? And in fact, they did. The HPV-independent tumors occurred more commonly in older patients, presented with a much larger median tumor size. And as you can see here, compared to conventional HPV-associated adenocarcinomas, more often presented at high stage, meaning stage 2 or higher. So based on that, the newest WHO, which was published in 2020, reclassified all cervical cancers based on etiology and linked to HPV. So you can see here, if you look at the adenocarcinomas, you can see highlighted here, that both in situ adenocarcinomas and invasive adenocarcinomas were separated by their HPV status. And you can see with the HPV independent tumors further classified into gastric type, clear cell type, and mesonephric type. See this other category here, and under those other category includes endometrioid adenocarcinoma of the cervix, which is an entity, but extremely rare. No more than 1% of all cervical adenocarcinomas probably arising in the setting of endometriosis. But more commonly, if you see something that looks endometrioid or serous, it's most likely a metastasis or extension from something in the upper tract. And then finally, adenocarcinoma NOS that really didn't fit into any other known category. So let's talk about the HPV-independent adenocarcinomas. We have gastric type, clear cell type, mesonephric type, and endometrioid type. So we start with gastric type adenocarcinomas. As I mentioned, there are about 10% of all cervical adenocarcinomas, although for whatever reason, it's a much higher percentage in East Asia, and is the second most common adenocarcinoma after the usual type. These are extremely aggressive tumors, much more so than endocervical adenocarcinoma usual type. And these are not driven by HPV infection. That's been really well established now, which has really important implications for HPV testing, as well as, in the era of HPV vaccination, will the percentage of these tumors increase over time? And of course, we need new therapeutic strategies because these tumors don't respond to conventional therapies that we give for HPV-associated tumors. Why do we call these gastric type tumors? This was first coined by Dr. Kojima et al., where they described these cervical adenocarcinomas with gastric morphology that were negative for P16, and they defined it as tumors that have clear or pale eosinophilic cytoplasm that was very voluminous with very distinct cell borders. And what they found was that these tumors were either negative or only focally positive for P16 and had worse overall and disease-free survival compared to those that did not have gastric morphology. And you can see here the variation in the histomorphology of these tumors, the abundant, voluminous, clear, bubbly eosinophilic cytoplasm with very distinct cell borders, which some people akin to plant cells, where you can see the cellulose lining. So the gastric type tumors have these very distinct cell borders. You can see here on the lower right, a tumor that maybe in the old days would have been called minimal deviation adenocarcinoma, and those are just gastric type adenocarcinomas that are at the very well differentiated spectrum morphologically. These tumors can also become very poorly differentiated, in which case they kind of lose all the characteristics with the voluminous cytoplasm and just look like poorly differentiated adenocarcinoma NOS. If you didn't know any better, this could look like a pancreatobiliary adenocarcinoma, and that's sort of how we can recognize them in the cervix, is when you have a tumor that looks like a pancreatobiliary tumor in the cervix. So both the Kojima paper and a follow-up paper that we did 20 years ago showed that indeed the gastric type tumors have worse overall and disease-free survival compared to the non-gastric or usual type. And even when we looked at stage 1 tumors only, you can see that the gastric type tumors do much worse. So how do we diagnose these? Are there any ancillary studies that can help us? Well, the positive stains are listed here. You may be familiar with HNF1 beta, which is commonly used to identify clear cell carcinomas, but what we found from our IACC study was that almost all cervical adenocarcinomas express HNF1 beta. So this is not a specific stain at all for clear cell carcinoma of the cervix. PAX8 is positive in about 2/3 of the cases, so you can have PAX8 negative cervical gastric type adenocarcinomas. There are usually CK7 positive, at least focally, CA9 positive, and about half show aberrant P53 staining, either the overexpression pattern or the completely absent null pattern. HIT1083 is an immunomarker that stains pyloric mucin. However, it's only available in Japan, so not really readily available to the rest of us. And this PAS Alcium blue, which obviously is not an immunostain, but is a histochemical stain, is really helpful to identify gastric type mucin, and I'll just show you that in a second. With very rare exceptions, the P16 should be negative or only focally positive. And again, with rare exceptions, the ER and PR should be negative. Because these have gastrointestinal phenotype, they will stain with CK7 and CDX2, at least focally. So here's an example of, on the lower end here, you can see cervix with what looks like gastric type mucinous changes in the glands. And this is a HPV-associated adenocarcinoma in situ here with some normal endocervical glands. And when you throw a PAS Alcium blue combined stain on it, you can see that the abundant apical mucin, gastric type mucin, is very pink or magenta and PAS dominant, whereas the normal endocervical glands have this very dark blue, Alcium blue dominant cervical mucin. And that's a really easy way to determine what kind of mucin your cervical glandular lesion is producing. As I mentioned, gastric type tumors should be P16 focal or negative, but there are always exceptions. Here's an example of a tumor that I thought was gastric type, but then the P16 was diffusely positive. So we went ahead and did the HPV in situ hybridization, which was negative in the tumor. And you can see it compared to the nice control of what HPV positivity should look like. As we know, gastric type adenocarcinomas, or formerly known as minimal deviation adenocarcinomas, are linked to Poitiers syndrome, which is an autosomal dominant inherited tumor with loss of function of the STK11 tumor suppressor gene. And of course, these patients have mucosal melanosis, hamartomatous polyps in the bowel, as well as gastric type adenocarcinomas and scatats in the ovary. But not all patients with gastric type adenocarcinoma have Poitiers. And in fact, STK11 mutations have been identified in sporadic cases. So what are the other underlying mutations or factors that drive these tumors? Well, we published a study recently looking at 68 gastric type adenocarcinomas. And what we found was that in line with the immunohistochemistry, almost half have underlying TP53 mutations, but like other mucinous tumors, they also have KRAS mutations, CDKN2A mutations, and in even SMAD4 mutations, which you may be familiar with in pancreatic adenocarcinomas. So SMAD4 is not specific to pancreatic tumors. So this is sort of the pathway that we think is the development of these tumors: gastric metaplasia / lobular endocervical glandular hyperplasia. I'm going to be talking about that in a little bit, which based on different kinds of mutations can develop into directly gastric type adenocarcinoma or be sort of morphologically very well differentiated, which we don't really use this term, but people may be more familiar with minimal deviation adenocarcinoma. So clear cell carcinoma, another rare type of cervical adenocarcinoma, about 3 to 4%. They can occur either in the sporadic setting or, as you may know, in patients who had in utero exposure to diethylstilbestrol. These tumors have the classic trifecta of tubulocystic, papillary, and solid growth with hobnails, with these very prominent nuclei that kind of protrude from the basement membrane. They can have abundant clear cytoplasm. Sometimes they can have more of an eosinophilic look to them. And as we know, back in the 70s, Dr. Herbst described the seminal paper in the New England Journal of Medicine that linked diethylstilbestrol exposure in utero to the development of these very rare tumors in both the vagina and the cervix, clear cell carcinoma. So clear cell carcinoma is rare even amongst DES exposed patients, so that while it's important to have DES as an underlying risk factor, it's not enough. So there must be other factors, either genetically or in their environment, that leads to the development of these tumors, but we really don't know that much about these. In terms of what drives these from a molecular standpoint, there's really not a lot out there. I have this work in progress in parenthesis because we have just submitted our molecular genetic paper on clear cell carcinomas of the cervix and are awaiting to hear whether it's been accepted or not. So once that comes out, I'll have more details to be able to share with you. In terms of the clinical presentations, these tumors have a bimodal age distribution. So the big peak is in the early 20s, late teens, and then another smaller peak in around 42 years of age. If you have DES exposure, the peak tends to be in the younger patients, and the tumors tend to occur in the anterior upper third of the vagina or the ectocervix. Whereas in the non-DES exposed patients, there's a much wider age range and the tumors tend to be endocervix predominant. Now, in terms of outcomes of these tumors, again, not a lot of data out there. This is another paper that we recently submitted and hopefully will be accepted soon. I'll just tell you that clear cell carcinomas, like gastric type, do worse compared to usual HPV-associated tumors, but the stage is very important, as the higher stage clear cell carcinomas do much worse than stage 1 clear cell carcinomas. In terms of ancillary studies, they stain like other clear cell carcinomas in other parts of the GYN tract. So they're CK7 positive, PAX8 positive. As I mentioned earlier, HNF1 beta, yes, positive in these tumors, but not specific to this type of adenocarcinoma in the cervix. Napsin A and racemase are really good markers for clear cell carcinoma, especially when your differential is something like, endometrioid or mesonephric type carcinomas. These tumors, usually ERPR negative, but I've seen positive cases. GATA3 tends to be negative. P53 can have either wild type or aberrant staining patterns, and P16 can be, diffuse strong or focal patchy or negative. So those don't really help in trying to determine, what type of tumor it is. Mesonephric carcinomas, probably the rarest of the cervical adenocarcinomas, comprising less than 1% of cervical tumors. There's a lot of morphologic heterogeneity in these tumors, which is sort of one of the defining features. And these are derived from male or Wolffian embryologic remnants. So they are not Mullerian tumors, but rather Wolffian tumors. And of course, Mullerian tract is derived embryologically from the fallopian tubes, fuse in the middle to become the uterus and the upper portion of the vagina. And you have the Wolffian system, which in the male develops into the mesonephric ducts, but in the female involutes. And so you have these remnants sort of along the lateral tracts of the GYN tract. And it's from these remnants that we think mesonephric tumors arise. So if you sample your cervix at the 3 and 9 o'clock, you will often find deeply seated these mesonephric or Wolffian remnants. They can become hyperplastic, which is still a benign process. But once they become malignant, they can have a lot of morphologic heterogeneity, from these tight little tubules with eosinophilic secretions to more ductal or endometrioid-like to papillary and clear cell-like to solid and spindle-like. And here's a nice paper describing all the morphologic variation of mesonephric carcinomas. And you can even get malignant spindle cell differentiation in these tumors, which then becomes a malignant mixed mesonephric tumor. Again, immunohistochemically, HNF1 beta usually diffusely positive in mesonephric carcinoma, so not helpful in your differential diagnosis. These are always PAX8 positives, always CK7 positive, and usually GATA3 positive, either focal or diffuse. TTF1, which you may be familiar with as being positive in mesonephric-like carcinomas in the ovarian corpus, tend to be negative in the cervical tumors. These are always P16 negative, ERPR negative, P53 wild type. And if your differential is with clear cell, again, racemase and napsin can be helpful because these are negative in mesonephric carcinomas. Older immunohistochemical stains like calretin, CD10, yes, they tend to be positive in these tumors, but they're very non-specific. So you want to do sort of a panel that includes all of these markers. As far as the molecular genetics, we now know that most of these tumors are driven by underlying KRAS or NRAS mutations. And this is based on work done by Merkovich et al. From 2015. They also often have mutations in chromatin remodeling genes like the ARIDs, and very often have 1q gains. In terms of the clinical outcomes of these tumors, you can see that the mesonephric adenocarcinomas are somewhere in between HPV associated and other HPV independent tumors in terms of overall survival. But when you look at progression-free survival, they tend to be similar with other HPV independent tumors. So mesonephric carcinomas are really rare, and because they're rare and because of their morphologic heterogeneity, are often misdiagnosed. The outcomes are likely stage dependent. However, they can be very aggressive, and the preferred site of metastases for these tumors is the lung. So oftentimes these patients will present with lung metastases, and it could even be like 5, 10, 15 years down the line. The outcomes are likely stage dependent, but look out for other high-grade components like a sarcomatous component. Endometrioid carcinomas, if you read the older literature, it's probably overestimated because the usual type endocervical adenocarcinomas were often called endometrioid type. Again, another very rare type of cervical adenocarcinoma. And if you see something in the cervix that really looks and stains endometrioid, you have to exclude that it's not coming from the uterine corpus. What you want to look for are confirmatory endometrioid features such as squamous metaplasia. And we think that either endometriosis or tuboendometrioid metaplasia are possible origins of these tumors in the cervix. Here's an example of an endometrioid carcinoma, and you can see that it's deeply placed, present at the deep margin, and does not involve the overlying mucosa. And though we didn't see endometriosis in this particular case, it's probably where this tumor likely arose from. And if you look at it on high power, it looks just like endometrioid carcinomas of the corpus or the ovary. You can even see some tumor infiltrating lymphocytes and this sort of MELF-like pattern here. Immunohistochemically, they stain just like endometrioid adenocarcinoma, so ER/PR positive, PAX8 positive, patch EP16. They are negative for HPV, negative for CEA in general. So if you, again, see something that looks endometrioid in the cervix, you really have to exclude a metastasis from the uterine corpus. And that's in comparison to our usual type endocervical adenocarcinomas. As I mentioned in the IECC, what you want to look for are easily identifiable luminal mitoses, lots of apoptotic bodies. And here on the right, very often what I notice with cervical adenocarcinomas are these very pointy tips of the villi, as opposed to the very well-rounded tips of endometrioid tumors, as you can see here. And that's just a soft criterion, it's not absolute, but this is a nice case of a true endometrioid tumor with ciliated or tubal metaplasia. Serous carcinomas, I have it in quotes because it's no longer included in the WHO. Way back when these tumors were first described by Jilks, they had a bimodal age distribution. And what they found was that for stage 1 patients, the outcomes were really no different from general cervical adenocarcinomas. But even back then, it emphasized the importance of excluding endometrial serous carcinoma. But now there officially is no serous type of the cervix, according to the WHO. And that's because in the era of CFIMing our fallopian tubes and understanding more the biology of where serous carcinomas come from, here's a couple of examples of tumors that you would have called serous carcinoma of the cervix. It even looks like there's an in situ component here. But when you look at the fallopian tubes, they have big tumors in the fimbriated end or stick. And these are, in fact, just drop metastases in the cervix. You can see here is a case that in the old days would have been called serous carcinoma, high nuclear grade, slit-like spaces, papillary growth. But when we did the HPV in situ hybridization, you can see that it's diffusely positive. So what this tells us is that HPV-associated usual type adenocarcinomas can mimic what we would have in the past called serous carcinoma. This is a really nice paper by Philip Ip that showed that both HPV-associated and HPV-independent gastric type tumors can mimic serous-like papillary or micropapillary growth patterns. So again, if you see something that looks like a high-grade serous carcinoma in the cervix, you have to make sure that it's not a primary cervical adenocarcinoma, either HPV-associated or HPV-independent. So most serous carcinoma cervix are likely variants of either other types of HPV positive or negative tumors or metastasis from a occult primary, including in the endometrium as well as the fallopian tubes and ovaries, and therefore not included in the new WHO. So now we go back to the WHO classification, and you can see here the glandular tumors and precursors. So let's talk about that. These are benign glandular lesions that now have their own individual chapters in the WHO. And if you break it down, you can sort of break down HPV negative cervical glandular lesions into benign, pre-malignant, possibly pre-malignant, and malignant. And so we just talked about these malignant adenocarcinomas. The other way to look at it is actually by the type of epithelium they have. So you can have gastric mucin type lesions, Mullerian type lesions, as well as mesonephric or other remnant type lesions. And so down here are the tumors that correlate with this type of epithelium. So let's talk for now about gastric mucin producing lesions. So this is the original paper that coined the term lobular endocervical glandular hyperplasia by Dr. Nucci and Dr. Young. These were described to be hyperplastic cervical glands that were either well or poorly demarcated. Glands often had this lobular configuration with a central dilated duct-like structure and small glands around the periphery. They could occasionally have reactive nuclear changes, and you can have some extravasated mucin that elicited a stromal response. And you can see here in the title, pseudoneoplastic comparison with 14 cases of adenoma malignum. So these tumors often mimicked minimal deviation adenocarcinoma as we knew them back then. And here's a picture that very much looks like what Dr. Nucci described, but in fact, this was almost at the exact same time, another publication by Dr. Mikami in Japan that coined this term, florid endocervical glandular hyperplasia with intestinal and pyloric gland metaplasia, a worrisome benign mimic of adenoma malignum. Again, similarly showing how these tumors can make you worried about a minimal deviation adenocarcinoma. So lobular endocervical glandular hyperplasia, here's a nice colorful picture. You can see this central big dilated type duct-like gland and a lobular proliferation of glands around the periphery. And if you look at them on high power, they kind of resemble gastric type glands. And if you look here, you can see grossly, they often have these big cystic Nabotian cyst-like glands along the periphery. And on imaging, what you see here, here's the corpus, here's the endometrial lining, and here's LEGH in the cervix. And the authors of this particular paper called it the cosmos pattern because it resembles this cosmos bipinnatus flower. And these LEGH lesions can actually have clinical symptoms like discharge. They can present as masses, they can look cystic. So they have this sort of floret-like pattern on imaging. On histology, again, it is a proliferation of endocervical glands that have abundant gastric or gastrointestinal type mucin, as you can see here. And you can see that they can often go very deep into the cervical wall. And you can see why people thought these were worrisome for minimal deviation adenocarcinoma. And again, just comparing LEGH type glands to actual stomach or gastric glands, and you can see the morphologic similarity here. And in fact, these cervical gastric type glands do produce gastric type mucin. And LEGH was shown to be a benign lesion. None of the patients that studied ever had recurrence. They did not find any HPV in these. And sort of related to that, you can get pyloric or simple gastric type metaplasia without the lobular configuration or hyperplasia. We really don't know what the significance of these lesions are, but you can see them on small biopsies or curettings. For example, here, this is an ECC from a patient who presented with watery vaginal discharge, and you can see the sort of big, abundant gastric type mucin in these glands, which without clinical history can actually be very difficult to diagnose. So here's another entity that looks very similar, as you can see here. This was first described in 1991 as diffuse laminar endocervical glandular hyperplasia by Drs. Young and Scully. And you can see I'm sort of showing you a theme here, all of these lesions, very morphologically similar, again, in their title, often confused with minimal deviation adenocarcinoma. And there have been several case reports of this entity since. And here's a nice example. So what you get with diffuse laminar endocervical glandular hyperplasia is the same sort of glandular proliferation, often with gastric type mucinous glands, but a very distinct line that usually separates it very neatly from the underlying stroma. And in the original description said didn't go beyond like the upper third of the cervical stroma, but I've certainly seen cases where they can go much deeper. And again, this very clean linear distinction between the proliferation and the underlying stroma. Now here's another old picture, as you can see from an old paper that looks just like all the lesions I've been showing you, LEGH, diffuse laminar endocervical glandular hyperplasia. But in fact, this was another case report series by Dr. Young calling these endocervical type A or non-cystic tunnel clusters with cytologic atypia. And they also said that these can mimic or be worrisome for minimal deviation adenocarcinoma. They can have some nuclear atypia, but these were called type A tunnel clusters. And so you might say, well, what are you talking about type A tunnel clusters? So tunnel clusters were first coined by Dr. Fluman in 1961, called focal hyperplasia or tunnel clusters of the uterine cervix. And he did this remarkable study where he took hysterectomies from 9 patients, serially sectioned all of the cervixes from all of these patients, looked at them under the microscope, and physically drew out each slide. And so you can see here, for example, this drawing corresponds to this plate here, and he described 2 types of tunnel clusters. So here, these are the type A tunnel clusters, which, I remember them as being angulated, so have these sort of angulated growths of the endocervical glands. And then the type B tunnel clusters, which we're all familiar with, which are the big inspissated glands filled with mucin that we see very often. So the link between tunnel clusters and gastric mucin came from this study from Japan, where they looked at these type A tunnel clusters. And you can see, again, tall apical mucin, distinct cell borders, mimicking gastric type glands, and showed that these did, in fact, on immunohistochemistry and histochemistry, express gastric type mucin. So we have all these gastric lesions in the cervix, LEGH, alternatively called pyloric gland metaplasia, tunnel cluster type A, diffuse laminar endocervical glandular hyperplasia. And what we now know is that they're all part of the same process of gastric type differentiation. So you have these tunnel clusters type A, which are not mass forming, these other hyperplastic lesions that can present either with or without mass formations. And what do these all have in common? They were all in their original description told to be, thought to be worrisome for minimal deviation adenocarcinoma. They usually lack atypia or any sort of obvious features of adenocarcinoma. They all have gastric phenotype, no obvious malignant cytology, and therefore, you could distinguish them from minimal deviation as long as you didn't find any of these other worrisome features. And so there was a lot of literature around this, differentiation from minimal deviation adenocarcinoma. We don't use that terminology again. Now they're all just called gastric type adenocarcinoma. You can, radiologically sometimes make that distinction where the LEGH is more multicystic and gastric type tumors are more solid. And then with immunohistochemistry, LEGH has wild type P53 and apical CEA expression, whereas about half of gastric type adenocarcinomas have aberrant P53 with more of a cytoplasmic CEA, but sometimes it can be very difficult to make that distinction. And of course, P16 is not helpful in this case because these tumors are not related to HPV. LEGH usually has a lobular configuration, but it can be very focal. You can have stromal reactions around these glands that mimic desmoplasia, so you have to be careful not to overinterpret that. But what about the ones that do present with cytologic atypia? What do we call those? How do we know they're not actually carcinomas? So next I'll be talking about this entity, atypical lobular endocervical glandular hyperplasia. And you can see here nice examples of the lobular configuration, very bland cytology, but then occasionally a gland that shows more cytologic atypia, enlarged nuclear prominent nucleoli, often coexisting together, and really didn't know, what the clinical significance of these were in the beginning. They can have nuclear enlargement. You can see the open vesicular chromatin, prominent nucleoli. Sometimes you can have this papillary configuration. Sometimes you can see apoptotic bodies or mitoses, but very rarely. And this was actually a nice study that sort of combined molecular as well as morphology atypical LEGH and showed that on comparative genomic hybridization, that LEGH actually has chromosomal imbalances that are very similar to minimal deviation adenocarcinoma, especially the ones that have cytologic atypia. So this was the sort of molecular morphologic link between LEGH and gastric type adenocarcinoma. There's another study by Dr. Mikami looking at P53 and Ki67 in atypical lobular endocervical glandular hyperplasia and found that the Ki labeling index was somewhere between LEGH and minimal deviation adenocarcinoma, and also showed that sometimes these atypical LEGH can have aberrant P53 expression. And yet another study that showed that lobular endocervical glandular hyperplasia is indeed a neoplastic process because many of them showed underlying mutations in GNAS, KRAS, or STK11, which are genes that are often affected in mucinous tumors. And then in 2017, this entity gastric type adenocarcinoma in situ was described. And this is the reason that this has now been included in the WHO, where you have normal glandular architecture retains just like in usual adenocarcinoma in situ, but you can have either cytologic or architectural complexity within those glands. And they showed gastric phenotype, HPV negative with minimal mitoses or apoptotic bodies. So we have atypical LEGH and gastric type adenocarcinoma in situ. We think they're all probably part of the same process, the same lesion, the same pre-neoplastic process, but that it's really just a difference of architecture. So in LEGH, you have that lobular hyperplastic proliferation, whereas in gastric type AIS, You may not have that, but you can still have colonization or partial replacement of normal endocervical glands by what looks like gastric type adenocarcinoma. The biologic behavior and malignant potential is really unknown, and it's difficult to do sort of prospective studies on these. But if you do see these on biopsy or curetages, complete excision with a cone biopsy is recommended. So this is sort of the spectrum of gastric producing lesions in the cervix, from pyloric gland metaplasia all the way to gastric type adenocarcinoma and these other previously described entities sort of within that spectrum. And again, here are all the pictures from the prior papers in the last few decades: tunnel clusters, diffuse laminar endocervical glandular hyperplasia, lobular endocervical glandular hyperplasia, pyloric metaplasia, now in color, all expressing gastric type mucin that become atypical and are likely precursor lesions forming gastric type adenocarcinoma. So we've talked about the malignant tumors. We've gone over these pre-malignant gastric type lesions. So let's very briefly go over the benign HPV negative cervical glandular lesions. So we have tubal endometrioid metaplasia, which you're all familiar with, often occurs in the upper part of the cervix. It's a common change that you see post-surgery or post-biopsy. The P16 is usually mosaic, but can be diffusely positive, which can be really difficult to interpret if your differential is with AIS. But really, you should not see the apical mitoses and apoptotic bodies that you would typically see in HPV-associated adenocarcinoma in situ. Mesonephric remnants I talked about in the context of mesonephric carcinomas. They're Wolffian remnants. They can become hyperplastic and can mimic carcinomas. Ectopic prostate is an entity that also has its own chapter in the WHO. I'll talk about this briefly in a minute, but these are, again, sort of remnants from the male development embryologically that can occur in either the vagina or the cervix. When they occur in the vagina, they're called tubulosquamous polyps, but when they occur in the cervix, we call them ectopic prostate. You're all familiar with Aries stella change, which is a benign metaplastic process associated with either pregnancy or exogenous hormone exposure, but can mimic clear cell carcinomas and can be very difficult to differentiate. And microglandular hyperplasia, which we usually see in the context of young women, childbearing age, possibly on hormones. The main differential here, especially when it comes very florid, is endometrioid carcinomas that mimic microglandular hyperplasia. So I just want to take a few moments to talk about ectopic prostate. This is usually an incidental finding sort of in the wall of the cervix. It looks kind of funny, and typically what you see is a mixture of glandular and squamotransitional epithelium intimately admixed. And when you do the prostate markers like NKX3.1 or PSAP, it'll stain the glands, as you can see here. So this was a nice paper by Dr. McCluggage, published this year, called Skene's gland derivatives in the female genital tract. And you can have benign Skene's gland derivatives, which is just the female counterpart to the prostate, where you have ectopic prostate in the cervix, again with the NKX3.1 and the PSAP. But what was interesting was that adenoid basal carcinomas, as you can see here, which are HPV-associated tumors, also express NKX3.1, which led us to postulate whether these adenoid basal carcinomas are derived from these ectopic prostate glands in the cervix. We don't really know, but it does raise an intriguing prospect. And finally, as you can see here, I have highlighted in blue this entity adenomyoma. Now, it wasn't shown in the WHO that I highlighted. In the WHO, it's under sort of biphasic or mixed tumors, but I wanted to talk about it because it kind of fits into this whole concept of tumors that mimic or are worrisome for minimal deviation gastric type adenocarcinoma. This is an entity that was first described in 1996 by Drs. Jilks, Young, Clement, Hart, and Scully, sort of like superstars of GYN pathology. And these are like adenomyomas that you might see in the uterine corpus. In the cervix, they're usually polypoid, but they can be intramural. They're biphasic in that they have an intimate admixture of benign mucinous glands and smooth muscle. They can have these really irregularly shaped glands with papillary infoldings, frequently with this lobular arrangement. And as you can see here again, may be confused with what we back then called adenoma malignum or minimal deviation adenocarcinoma. Now, there's a more recent paper by Dr. McCluggage that kind of expanded the morphologic spectrum of these tumors and showed that there are both endocervical and other novel variants of adenomyomas in the cervix. Again, the patients can present with copious watery discharge. You can have gland rupture with mucin extravasation. Sometimes the smooth muscle cells in the adenomyomas can be symplastic or very bizarre and atypical. They can have some adipose tissue admixed with it. And what they described was that you can even get mesonephric type glands seen in these adenomyomas. So here's an example of a typical cervical adenomyoma. You can see here, this one in particular is very polypoid. You notice the lobular architecture of the glandular proliferation, the intimate admixture of the smooth muscle with the glands here, which are very mucinous in this particular example. You can see, again, another polypoid example here, intimate admixture of muscle and mucinous type endocervical glands. Sometimes they can just be polyps that can be excised. And when you look at them, they look like polyps, but in fact, they have this expansile smooth muscle, which you don't typically see in the cervix. But again, on low power, you can see that lobular configuration of mucinous type epithelium. When you go on high power, again, on the left here, I think now I've shown you so many pictures, you can recognize the tall apical mucin, small pycnotic nuclei at the base, expressing likely gastric type mucin. What's interesting about the adenomyomas is that they will usually have ER expression in those mucinous glands. But if you do a PR, the PR tends to be negative, which is sort of interesting. And again, another entity that you might mistake as quote unquote minimal deviation adenocarcinoma, again, gastric type adenocarcinoma. So how do you make that distinction? Well, the adenomyomas are usually really well circumscribed, they're polypoid, they have bland cytology, no desmoplasia. Seeing that lobular architecture is really important. And because this is a biphasic tumor, often has intimately associated smooth muscle component and is ER positive. Whereas if you're thinking about gastric type adenocarcinoma, that's really well differentiated. Even when it's well differentiated and cytologically not that atypical, it's usually an ill-defined mass that expands and infiltrates the cervical wall. You have to see at least focal, severe atypia and stromal desmoplasia or infiltration with irregular glands that don't have a lobular architecture. And these are always ER negative. So in summary, we went over the malignant HPV negative cervical adenocarcinomas, gastric type being the most common of these. We went over the possibly pre-malignant lesions that are all gastric type in their phenotype, from lobular endocervical glandular hyperplasia to diffuse laminar endocervical glandular hyperplasia and tunnel clusters to atypical LEGH and gastric type adenocarcinoma in situ. And we ended off with all the benign HPV negative lesions that can mimic malignant processes, but just to be aware of these new entities, ectopic prostate and adenomyoma that you can also see in the cervix. And that is the end of my talk, and I'm happy to take any questions.
Thank you so much, Dr. Park, for this excellent talk on so many different entities that you have covered. So there are a couple of questions that I see online. So one question is, I think you might have already covered it, that is minimal deviation carcinoma no longer an entity? That was a question from one of our viewers.
Yeah, so we don't recommend using that term anymore, that if you have a tumor that looks like what you would have called minimal deviation in the past, we just call it gastric type adenocarcinoma. And that's because there was a study that we did that looked at gastric type adenocarcinoma outcomes, and we separated out tumors that look like what, in the past we called minimal deviation adenocarcinoma, really well differentiated with minimal, invasion, like obvious invasion. And those tumors did just as badly as the ugly, poorly differentiated looking gastric type adenocarcinoma. So there's no point in saying that it's well differentiated or minimal deviation, because they are also just as aggressive. So we don't recommend using the term minimal deviation, and it's no longer in the WHO.
Right. Thank you, Dr. Park. There is another question which is about the gastric type adenocarcinomas. And the question is that what are the regular immunostain panels that you use to differentiate from a metastasis?
Yeah, so if you have a site that's involved by something that looks like gastric type and you don't have any clinical history, there's really very few stains that you can do. PAX8 is one that if it's positive, it's helpful because about 2/3 of cervical gastric types will be positive, at least focally. But if the PAX8 is negative, it doesn't really help you. You can't even really do molecular studies because the molecular genetics of gastric types are almost identical to pancreatobiliary tumors. They have the same genes that are affected. So other than PAX8, there's really not much in terms of ancillary studies. So the clinical information here is the most important. I'll say that if you have a cervical gastric type adenocarcinoma that's metastasized, you're going to see a big mass in the cervix. If you have a pancreatobiliary tumor that's metastasized to the cervix, then that's a very advanced pancreatic adenocarcinoma, and you'll see that also clinically. So in a setting of metastasis, the clinical radiologic is going to be the most important.
Thank you. There is another question about the benign entities. The question is that you have mentioned several benign entities like which can mimic malignancy. So what is your practical approach to differentiate it from an adenocarcinoma?
Right. So if you're talking about, LEGH, all those benign hyperplastic gastric lesions, the morphology is the most important because if you're talking about gastric type adenocarcinoma, you really need to see infiltration, high nuclear grade, desmoplasia. You can't make a diagnosis of adenocarcinoma without seeing at least some of those features. Now, if you have a small biopsy, are there any stains you can do? If you do a P53 and it's aberrant, then that's helpful because then you're more likely dealing with an adenocarcinoma. But if it's wild type, it doesn't help because you can have wild type P53. ERPR can be helpful depending on what your differential diagnosis is. Unfortunately, LEGH and all these other benign gastric lesions tend to lose ERPR, but if you have ERPR positivity, it's unlikely to be an adenocarcinoma. Some people use PAX2. I don't use it because we don't have it here, but PAX2 has been published as something that can differentiate between benign and malignant cervical glandular lesions, regardless of HPV status. So that's, if you have PAX2, that can be helpful, but again, we don't have that, so I don't have much experience using that. Other than that, it's very difficult. And I actually get a lot of consults where it's hard to, distinguish benign from malignant. The most important thing is to be able to examine the whole thing histologically. So a big cone biopsy is often necessary, especially if you see something on a biopsy where you're not sure. And if you can examine the entire lesion and there's no obvious desmoplasia, no obvious infiltration, no severe nuclear atypia, then that's the best way to make that distinction.
Right, thank you. There is another question. Do you have any experience about CDX2 and in its role in differentiating from metastasis from digestive tract?
Yeah, so these gastric type adenocarcinomas, in my experience, always have a little bit of CDX2, always. So I've never seen one that has like diffuse strong CDX2, but that doesn't mean that doesn't happen. So if your differential is with like colon cancer, for example, the CDX2 won't be helpful. The main differential here is with upper GI pancreatobiliary because both those tumors and gastric type adenocarcinomas have CK7 positivity, CK20 positivity, CDX2 positivity, even SATB2 I've seen expressed in gastric type adenocarcinomas of the cervix. So there really isn't any marker that's going to be a slam dunk help to you, unfortunately.
Right. On that note, there is an additional question from a viewer. What about SMAD4? Does it help in such setting?
Right. So as I mentioned earlier in the molecular genetics of gastric type adenocarcinoma, we found that a small percentage of cervical gastric types have underlying SMAD4 mutations. And I think there's a paper that showed that you can have SMAD4 IHC loss in gastric type adenocarcinomas, although the proportion is much less than in pancreatic adenocarcinoma. So if you do SMAD4 and it's lost, you can suggest that it's pancreatic in origin, but it doesn't exclude that it can be cervical in origin, unfortunately.
Right. So on a biopsy, it seems like that one has to give a differential diagnosis and the clinical context needs to be taken into consideration. Is that correct?
Yeah, I mean, it all depends on where the biopsy is coming from. If you're biopsying the cervix and you see something that looks like a gastric type adenocarcinoma, chances are it's cervical in origin. If you're biopsying like omentum or some other metastatic site, then there's really no way to tell. You have to do the clinical radiologic correlation there. Yeah.
Right. Thank you again. And here is another question about the benign lesions. That is there any difference prognosis-wise regarding between area stellar reaction or like, I mean, tunnel clusters or microglandular hyperplasia?
No, I mean, those are all benign, right? And so for us as pathologists, the biggest difficulty is making sure that we call it benign as opposed to one of its mimics that can be malignant, right? So with area stella, obviously the most difficult challenge is distinguishing from clear cell carcinomas, and area stellas can have mitotic figures, they can be ERPR negative, right? So the overall architecture in that case is really important because area stella tends to be, focal metaplastic process as opposed to mass forming. Microglandular hyperplasia, again, a benign process, but can mimic a malignancy, especially endometrioid adenocarcinomas that can have microglandular hyperplasia-like features. So yeah, in and of themselves, these benign entities are benign and you don't have to do anything. It's just for us as pathologists, they can be diagnostically very challenging. So we just need to be aware of the challenges and make sure we don't over or undercall these lesions or their mimics.
Thank you. Here is another question. It's that, is it the terminology glassy cell carcinoma no longer used?
It is no longer used. So if you look at the WHO, the classification, the adenocarcinomas are separated into HPV associated and HPV independent. And in the HPV associated chapter, it covers, all the other sort of previous entities that were in the old WHOs. So no, glassy cell is no longer considered to be a true entity. If you see something that looks like a glassy cell, I would do immunos on it to determine whether it's more like a squamous cell that has, sort of clear cytoplasm, or an adenocarcinoma that has clear mucin. That's sort of what we recommend doing and not calling things glassy cell carcinomas.
Thank you again. I think these are the questions that I found online from our viewers. Let me just have a last look if I have missed anyone. No, I think these are all the questions that we have.
Great.
And thank you again, Dr. Park, for this excellent talk on this important topic about HPV negative cervical glandular lesions. And you would be happy to know that there were a couple of hundred viewers who joined from different parts of the world, and I could keep track of some of them. Someone joined from Cambodia, Belize, that's in Morocco, I guess, and Greece, then Turkey, Bangladesh, India, Brazil, then someone joined from Kosovo.
Wow.
And thanks to all of our viewers, and someone also joined from Romania and Bolivia as well. And thanks to our viewers for the support. And if you like the lectures, please don't forget to subscribe to our YouTube channel, that is Pathcast, and you can also follow and like the Facebook page so that you can get updated with all the upcoming talks. And we have a website that is pathologicast.com where all the lectures are organized subject wise, and there are so far 18 GYN pathology lectures, so you can have all of them on the YouTube channel as well as the website. So our next lecture is coming up on December 7th, and we will be having a GI pathology lectures, and Dr. Emma Furt will be presenting from University of Pennsylvania, and she will be talking about gross pathology in GI specimens. So hope to see you at that time. And thank you again, Dr. Park, and thanks so much.
Thank you so much.
Thank you.